Just want to say thank to the organizers, Kumar sir and Patil sir and Akshay sir for giving me this opportunity. I tried to join the meeting, but because of flight issues, I'm not able to join the meeting in person. I don't have such data which my dear friend Dr. Vasu until now presented is all phase 3 data. But for me, I have only some retrospective studies which have some hints towards which we can use with respect to the variants and ALK inhibitors efficacy. I just want to, can you please next slide? And this already discussed so many times. This ALK has can join with any of the things. The most common one is EML4. The other partners can be like remaining all other. In with respect to EML4, where the splicing was done, they based on that the remaining variants will come. Variant 1, 2, 3. So many variants are there. Next slide. And this is the same which I have told until now. Next. And there are so many retrospective studies was published from Asia, Japan, Chinese group and South Korea group. And the most common partner was EML4. Other than that, remaining other partners will come into the part. With respect to the EML4 partners, the most in some studies, the most common one is variant 3. In some other studies, the most common one is variant 1, but more or less either variant 1 or variant 3 are the most common, and followed by variant 2 or variant 5. And the one more significant group was other partner other than EML4. Next. This was the first retrospective analysis published based upon a response of the ALK positive lung patients with respect to treatment based upon variants. And the first graph one is with respect to these are the different variant 1, variant 2 and variant 3 and non-EML4. If you look at the left one, this is a response with respect to the platinum agent. First one is EML4 and the second one is non-EML4. The curves are almost overlapping with each other. Then look at the right one, almost more or less with respect to the different variants in EML4, all are overlapping with each other. If you look at the down, the left side also, there is some gap between the curves on left side, that is EML4 and non-EML4. This is based upon the treatment with respect to, based on this is with respect to the treatment with pemetrexed. And right side one is with respect to the variants. Variant 1 is doing a bit better compared to the remaining variants, variant 2 and variant 3, when we are treating with pemetrexed. It's a just hint with respect to the variant and based upon the treatment. It's a retrospective analysis, and n number is also matter. That's why out of this platinum based treatment and pemetrexed based treatment is doing a bit better with respect to the variant 1 compared to the remaining variants. Next slide. And this is the first graphs was with respect to the crizotinib treatment. The lower one was with respect to the setinib. If you look at crizotinib and left side, almost curves are overlapping, and right side also almost curves are overlapping. And with respect to setinib, left side as curves are overlapping. In right side, if you look at the yellow one is the variant 2. That is only one patient. He got a CR with setinib. It may be difficult to interpret it like all variants are doing wonders with setinib. It's only single patient. That's why it will be difficult to draw conclusions from this single patient. But more or less in this retrospective analysis, one hint was whenever we are treating all positive lung patients with pemetrexed based therapy, the variant 1 people were doing far better compared to the remaining variants. Next. This was the next. This was the second study which was published. This is also a retrospective analysis, but this is the treatment is with only crizotinib. This is there is no the entire patient's population was treated with crizotinib. There are no second generation inhibitors. There are no third generation inhibitors, and there is no chemotherapy. Whenever we are treating with crizotinib, left side was comparison between variant 1, variant 3, and remaining variants. Almost all curves are overlapping with each other. Right side also there is no big difference between variant 1 and variant 3. This is the one study which came a bit different with respect to the remaining studies, where variant 1 and variant 3 not show much difference with crizotinib. There may be the remaining, as we know, this is a retrospective study, and n number is also different and patient population may be different. That's why it will be difficult to draw conclusions. Next, this is the first study which showed differential response of the variants whenever we are using crizotinib. This study was published. This is also ALK positive patients which are treated with crizotinib. The left one is, but they divided into two types. One group was only variant, the other group was non-variant. If you look at the PFS of variant 1 with crizotinib, it's almost 11 months. Whenever in non-variant 1 group, the PFS was 4 months. From this, what we can tell was the variant 1 group was doing bit better compared to the remaining variants whenever we are using crizotinib. That's what we can draw a bit conclusion from this retrospective analysis. Next, this is one more retrospective analysis published. This is, but here they used ALK positive patients which are treated by ALK, crizotinib, setinib, and alectinib. The left graph was with respect to the only crizotinib. That is, here they divided patients into one was variant 3, another one is variant 1 and 2. Here, if you look at the blue graph, this is variant 3. It's obviously we can come to conclusion like variant 3 was not doing good with crizotinib. If you look at the right graph, there also there is a big separation of curves between blue and yellow one, and the right one is whenever we are using ALK positive patients with all three. This is the whole population like crizotinib, setinib, and alectinib. Still the curves are separated, variant 1 and 2 and variant 3. Here we can easily say like variant 3 was not doing better with either crizotinib or setinib or alectinib. Next. And this is same group, but this is an in vitro study where they want to see the minimum inhibitory concentrations of the drugs. If you look at the down one, their variant 3 and variant 5 inhibitory concentrations were far a bit away from variant 1 and variant 2 whenever we are using these three drugs. Next. And this is also same study, and but there they took one culture cell line. Here they took different cell culture, but more or less the results were same. Whenever they are looking at variant 3 and variant 5, the minimum inhibitory concentrations of the drugs needed, crizotinib, setinib, and alectinib, was more compared to the remaining variants 1 and variant 2. Next. And this is the same, like just look at the crizotinib, setinib, and alectinib, variant 1 and variant 2, these are 24, 57, 22, 16, and 17, 12. But whenever come to the variant 3 or variant 5, these are the minimum inhibitory concentrations which are necessary. Means it's indirect, it is an evidence like variant 3 was doing bit different, variant 3 and variant 5. That's what they came to conclusion. This is because of the difference in the structure of variant 3 and variant 5. These two variants are a bit stable variants, whereas remaining variants, variant 1, 2, and 7, these are all unstable variants because of their structure itself. That's why they are more sensitive to the ALK TKI inhibitors, whereas variant 3, variant 5 are a bit resistant to the first generation and second generation ALK TKI inhibitors. Next. This is recently published from Chinese group. They also looked into the same, but they divided into they want to see whether this variant 3 and variant 5, as we based on previous publication, they came to know like variant 3 and variant 5 are a bit different. That's why they want to see the population to divide it into resistant variants and remaining variants. As we all expected, variant 3 and variant 5 were doing a bit worse compared to the remaining variants. Next.
Kishore, you need to conclude in next half a minute.
Yes, ma'am. Yes, ma'am. Only 2 slides. Next. This is based upon 3 trials. Until now, what we have seen was all our retrospective studies. This is based on these 3 trials: Crown, Alex, and ALT. And this first one was lorlatinib, and lorlatinib, whenever if you look at the both graphs like green one and red one, more or less equally same. Means both if it is variant 1 or variant 3 are doing a bit morely equal with lorlatinib. If you look at the alectinib and brigatinib, the distance between the bar charts was a bit more. Means variant 3 was not doing good with alectinib and brigatinib. These are with respect to crizotinib in remaining trials. Next. And next. This is crown data. As we all know, if you look at the variant 3, the median PFS was roughly 33 months with lorlatinib, which is 5 months with crizotinib. And the remaining variants, more or less, crizotinib also doing same as lorlatinib. Whereas with respect to the variant 3, the magnitude of benefit what we are getting with third generation ALK inhibitor was a bit more compared to the remaining ALK inhibitors. Next. Same what I told previously, 33 months and 5 months. Next. This is my conclusion, like out of all variants, the variant 3 and variant 5 were structurally different from the remaining variants. That's why they are more stable variants. Per se, they are not doing good with first generation and second generation ALK inhibitors. Based on previous analysis, what they have done in Crown data, variant 3 was doing a bit better with lorlatinib compared to the remaining inhibitors. For variant 5, I don't have any, I'm not able to find any data. That's why up to me, the variant 3 or variant 5, it's better to consider third generation ALK inhibitors. Thank you.